Simple, but oh so complicated. Let's see if we can make it as simple as it looks. Am I the only one with incontinence? You're not. It's a closet problem. 2 million men in the world suffer loss of urinary control. I'll bet that number is the 10th power of that. What do you expect when you go to the doctor's office? Well, the first thing you have to be ready for and willing to do is open up. Speak about your problems. Develop a relationship with the doctor so that the two of you can work together to solve this problem. And if you're not comfortable enough to do that, something has to change. You have to change, or the doctor has to change, but you need that level of interaction. The physical examination, again, looks at the nervous system a lot. And the things that will be done is your urine will be evaluated under a microscope. The examination will be a physical exam, but the pelvis, the lower abdomen, prostate will be carefully studied. And when you void, the question really is, do you empty your bladder completely, or is there a significant amount of fluid left within it? And that's residual urine. And then there's a study which we call urodynamics. Now the bladder is unique because it has a characteristic that is very useful to make it a storage device. Silly putty.
Silly putty.
When I stretch that silly putty, not much really happens, does it? That's called compliance. The bladder muscles are very compliant. This is a big rubber band. We know what's going to happen when I let go of this, don't we? That has some compliance because they can stretch it, but it certainly doesn't have the compliance that this does. That is the difference between storage and emptying. So filling and storage involves compliance. That's the Play-Doh feature. Urine stored at low pressure, and when the time is right, your central nervous system will give you the message that it's time. You'll seek out a location and you'll tell your bladder, go ahead and contract. And that's really what normal emptying is all about. This is the male bladder. I wanted to just put this in context of where it is anatomically with the prostate in the middle, so we have to take whatever's going on there into consideration. And then, of course, the urethra to make sure there's no narrowing. So urodynamic testing. This is a urodynamic system, and we can then print out a filling, a storage, and an emptying phase on a printer, and it all comes out with all this information layered. Now we're looking at the bladder, and here's a normal bladder. It fills with very little increase in pressure, and then at a certain volume, the message comes that it's time, and we begin to look for a facility, and we go through the emptying phase. Here's an unstable bladder. Just a little bit of urine, the pressure jumps up, and this is when you have that urgency and you begin to dance, trying to figure out what you're going to do next. And if you don't figure it out fairly soon, you'll have wet pants, and that's an unstable bladder. Overactive bladder, you hear this a lot. The image that this brings to my mind is the cab driver stuck in New York traffic, Pavarotti on the radio, and he's sitting there, I gotta go, I gotta go. Well, what's happening is the compliance of his bladder isn't working the way it should, and he's having unstable contractions, and that's his plight. These are a list of the medications. Those of you who have had these kinds of problems are probably familiar with Ditropan, Detrol, Vesicare, and Nabalex. These are all taken on a once-a-day basis. This is how it works. You take the medication, you get the dosing right, and the level of instability or inappropriate contractions diminish. And if you were measuring this with urodynamics, you see a decrease in the pressures that are generated. This is one of the sustained release mechanisms. The pill, as it's going through your gastrointestinal tract, absorbs fluid, the sponge expands and pushes the medication out, so you have an even dosing over a fairly long period of time. What else could we consider? Why would a bladder be unstable? Probably a lot of reasons, but here's one theory. When we're infants, we really don't care about the social environment. My daughter has twin boys, and I've seen a number of fountains. There's another nervous system. We call it a primordial nervous system. It kind of takes care of our needs. That primordial nervous system has a group of nerves which we call C fibers. As we learn to be potty trained and become socially appropriate, the primordial nervous system tone diminishes significantly. But in some people, it's reactivated. So what would that mean if you had a mature nervous system that now has to contend with a primordial resurgence? If you've ever been to an amusement park, you've probably seen bumper cars. You get in the bumper car, you turn the thing on, boom, boom, boom. That's what C fibers do to a normal, mature nervous system that's controlling the bladder. So what we're interested in is trying to find a way to block that situation. And through this we can put a very fine electrode, and we can lay it right down next to a nerve. And we can connect that then to a unit that's worn on the belt, and various levels of signal can be sent through that essentially quiet the C fibers or the bumper cars. This is an Interstim pacing system or neurostimulator. This unit is placed in the buttock, and that can eliminate incontinence because it stops the bumper car mechanism. This is the sphincter mechanism at the bladder neck, and we're injecting collagen, and we're bulking it to hold the urethra closed so we don't lose urine. We've done all these things and we still have a problem. What do we do next? The sling is in place, and it holds the urethra and the bladder neck up. So let's look at this. First off, it's for mild to moderate incontinence, a low pad count. It doesn't involve a lot of surgery. It's pretty straightforward. Continence, when you select the patients correctly, it's very rapidly restored. And this is really the only incision there is. But the bottom line is, this is a good surgical fix for the right patient. Surgical procedure that can be easy and very effective. Well, we decided our pad count's too high. This is the artificial urinary sphincter. Highly implanted. The reservoir is in the abdomen. The cuff is around the urethra, and the pump is in the scrotum. So here it is in action. The reservoir is full, the urine is flowing, now the bladder is filling, and now we're back where we started from. This has made people's lives who have, for instance, been saved from, let's say, a significant prostatic malignancy but have had incontinence. This device has turned their life from better to great. It's gold standard, it's a short operation, and most of the patients that have it would recommend it to their friends. Summarily, continence is treatable, continence is curable. You have to want to be dry, you have to have certain physical characteristics, you have to be able to open up and share your thoughts with people who are available to care for you so they understand what your problem is, and you have to be willing to undergo some testing. We really have an answer to this problem.